Simon Cancer Center, Exhaustion in Cleveland. Pleasure to be here. Thank you to the organizers for having me. We had a fantastic group of abstracts. We have 6 total abstracts selected for presentation. And the way this is going to go is, we're going to do 3 blocks of 2 each. So we'll have 8-minute presentation. We'll do 2 presentations. Then we have a Q&A session for about 13 minutes or so. And then we have the next 2, okay? And so with that, again, welcome. I'm going to ask Dr. Renee Salaby to get things started. She's going to talk to us about emotion 151 molecular signatures and as predictive for outcomes in the Javelin renal trial.
Good afternoon, everyone. Thank you for staying for this last session. I'm very honored to present our work in front of all of you. So this slide might be useless after Dr. Renee's talk this morning. It was brilliant. But the last couple of years, we witnessed amazing changes in the landscape treatment of clear cell RCC, with 5 IO-based combinations that were approved in first-line metastatic. And despite great advances in survival and response, a group of patients still doesn't benefit from these treatments, with PD ranging from 5 to 18%. And that's without mentioning recurrence and adverse events. So with so many drugs and many elements to take into consideration, it has become increasingly difficult for clinicians to pick the right drug for the right patient. And to palliate to this unmet need, biomarkers efforts have fallen into 3 categories: immunohistochemistry and immunofluorescence, genomic, and in the last years, RNA-seq. So let's take a closer look. An important effort by the Seniority Lab showed that the combination of tumor cell PD-L1 combined with the density of CD8 cells that are PD-1 positive, TIM3 negative, and LAG3 negative was associated with improved outcomes. Genomic profiling yielded some disappointing results, with tumor mutational burden, an approved biomarker in other tumor types that was not associated with response. On the contrary, loss of function of PPRM1 and the double mutant of Javelin renal 101 yielded some interesting results. In RNA sequencing, we had some interesting and promising results, but they were individual, and we could not really validate them in other trials. And the most promising work is the iEmotion 151 clusters. But can these clusters predict outcome? So what are the iEmotion 151 molecular signatures? Moser and colleague leveraged the big dataset of the Emotion 151 trial with more than 800 patients and used the RNA-seq data to identify transcriptionally defined clusters in an unbiased way using non-negative matrix factorization. So the 7 most robust groups were as follows: the androgenic and stromal and androgenic groups that are highly androgenic clearly, but were some specifiers. Group 3 that was enriched in complement and oxidation genes, group 4, 5, and 6 that were enriched in proliferative genes, with group 4 being highly immunogenic, and finally, group 7 that was enriched in small RNA expression. And the interesting part is that group 4, 5, and 7 favored PFS in the atezo-bev arm. The iEmotion 151 signatures help select the right treatment for each patient. So today, trials are being built based on these signatures, as we heard yesterday in very interesting talk. So that makes them really clinically relevant. But if we take them in another regimen that is very similar, are they still predictive of outcomes? To answer this question, we reproduce the methods used in the Emotion 151 trial, but this time in the Javelin renal 101 dataset. And just as a reminder, Javelin renal 101 compared avelumab and axitinib to sunitinib, leading to the FDA approval of the combination. So, what did the clusters look like in our dataset? As expected, groups 1 and 2 were highly androgenic. Group 3 was enriched in complement cascade genes and oxidation genes. Groups 4, 5, and 6 were enriched in cell cycle genes, with group 4 being enriched in T effector genes. Cluster 7 did not contain a lot of patients, so 1 patient per arm, and is not represented on this slide. Now, our first assumption to validate these clusters is that they would appear in same proportions in another big dataset, so the Javelin. And as you can see here on the left, the proportions were grossly similar between two trials, which means that these clusters are true transcriptional states in clear cell RCC. Now let's look at the IMDC distribution. So in the favorable group, we see that androgenic clusters 1 and 2 were more present, whereas in the poorest groups, we see that immune and proliferative groups are more represented. So now that we saw that proportions are grossly similar between trials, do the molecular clusters predict response? While androgenic clusters favored response, not statistically, but numerically, in the sunitinib arm, immune and proliferative clusters favored response in the atezo-bev arm. However, in the Javelin Renal 101, response rate was higher in axiavilimab, regardless of molecular clusters. Now let's look at PFS. Did molecular clusters predict PFS in Javelin Renal 101? Well, in the emotion trial, group 4, 5, and 7 favored PFS in the atezo-bev arm. Avelumab and axitinib did better, regardless of molecular clusters again, in PFS. And what's interesting is that this difference was statistically significant in the angiostromal group. To conclude, let's go back to our big questions. Are these molecular clusters real? So in terms of distribution, they are, and as we can see, distribution were grossly similar in both trials. But can they predict outcomes in an FDA-approved treatment regimen? Unfortunately, we saw that outcomes were better in the axiavilimab group, regardless of the clusters. Some caveats in our study that are worth mentioning is that the overlap of the profile genes were not exactly the same between iMotion and Javelin. And we still don't know if these conclusions apply to other regimens. And we saw some interesting associations, but the future will be probably made of multimodal markers that may be adapted to each agent more than each regimen. I would like to thank, first and foremost, the patients and their families. And I may be presenting, but there's a big team behind this project. My mentors, Dr. Shwari and Dr. Brown, Dr. Shukla, Tejas, Valisha, and Chris, all the co-authors and the Pfizer team, as well as my friends and colleagues at the Brown Lab and the Shwari Lab. Thank you for your attention.
That's great. Great, good job. And also from Dana-Farber, we have Dr. Chris Labaki. He's going to talk to us about tumor microenvironment in chromophobic RCC. So take it away.
Thank you very much. So I'm Chris Labaki, and I will be presenting today our work on the molecular characterization of the tumor microenvironment in chromophobic RCC and related oncocytic neoplasms.
Good.
So I will be presenting today our work on the molecular characterization of the tumor microenvironment in chromophobic RCC and related oncocytic neoplasms. So starting here with a brief overview of renal oncocytic neoplasms. First, there is the renal oncocytoma, which is a benign tumor characterized by limited chromosomal abnormalities and some mitochondrial defects. The low-grade oncocytic tumor is the second benign renal oncocytic neoplasms, and it's a novel entity that has been very recently described. And finally, chromophobic RCC is a malignant tumor characterized by multiple chromosomal losses and mitochondrial molecular alterations. And this can be pictured as a spectrum ranging from the most benign to the most malignant tumor. So first, we asked a question related to chromophobic RCC. How do patients with metastatic chromophobic RCC respond to IO-based therapies? To answer this question, we interrogated the IMDC database, and we looked at the survival outcomes of patients with chromophobic RCC as opposed to patients with clear cell RCC treated with IO-based regimens in the first-line setting. And we could clearly see that patients with chromophobic RCC present with poor survival outcomes. Now, the question is why? To answer this, we conducted a translational analysis using single-cell data. And so here's an overview of our cohort. We had overall 5 patients, 3 of them with chromophobic RCC, 1 patient with LOT, one patient with RO. All of these patients had localized disease. You can see the distribution of the tumor stage. We had, for most patients, tumor and adjacent normal samples for which we performed single-cell RNA-seq and single-cell TCR-seq. And finally, we evaluated the infiltration of CD45 positive immune cells in most of the tumor samples. So showing here first an overview of the cellular populations in renal oncocytic neoplasms. This represents around 47,000 cells. We identified myeloid populations, lymphoid populations, of course, the tumor cells, along with normal cells of the kidney from the adjacent normal samples, and finally, endothelial cells and cancer-associated fibroblasts. So going back to our initial question related to the poor response to immunotherapy in Chromophobic RCC, we tried to look at this through the determinants of response to ICIs, which we divided into three main pillars. The first one being the immune infiltration, so whether immune cells are present in the tumor. The second one being the immune exhaustion profile, so whether immune cells in these tumors actually express immune checkpoints. And finally, the tumor specificity, so whether T cells from Chromophobic RCC and renal oncocytic neoplasms actually recognize tumor antigens or whether they are not specific for these antigens. So how immune infiltrated are oncocytic tumors? We evaluated CD45 positive immune cells in all renal oncocytic neoplasms and clear cell RCC. And we could clearly see a very low infiltration of immune cells in all renal oncocytic neoplasms as opposed to the clear cell variant. Now, what is the exhaustion profile of renal oncocytic tumors? We first look at the TCGA database using bulk RNA-seq data. We looked at Chromophobic RCC as well as clear cell RCC and papillary RCC. And we clearly saw a much lower expression of all immune checkpoints in Chromophobic RCC as opposed to the clear cell variant. We further looked at this at higher granularity. We looked here at CD8 positive T cells using single-cell RNA-seq data in clear cell RCC and our own cohort of Chromophobic RCC, LOT, and RO. And we clearly saw much lower expression among CD8 positive T cells in Chromophobic RCC as opposed to clear cell RCC. So there is a very poor exhaustion profile in renal oncocytic tumors. Finally, do T cells from oncocytic tumors actually recognize tumor antigens? To answer this question, we used the single-cell TCR-seq data that was generated, and we try to look here at the mapping of this data with the VDJDB database of known epitopes. Specifically, we looked at TCR's mapping to viral antigens. So these would represent bystander T cells that are not specific or that do not recognize tumor antigens. We clearly saw a much higher mapping to viral antigens in Chromophobic RCC as opposed to clear cell RCC. To further validate this approach, we looked using single-cell RNA-seq data in CD8 positive T cells at the neo-TCR8 signature, which has been recently described and which is specific among CD8 positive T cells for tumor-specific T cells. And we saw a much higher expression of this signature in clear cell RCC as opposed to Chromophobic RCC, LOT, and RO. So in conclusion, there is a lower tumor specificity with a higher proportion of viral-specific T cells. So there is a poor response among patients with Chromophobic RCC to IO-based regimens, especially as opposed to clear cell variant. This can be explained by some of the characteristics of the tumor microenvironment in renal oncocytic neoplasms, including low infiltration of immune cells, a poor exhaustion profile, and very low tumor specificity of T cells. There are potential implications for therapy, including the reinvigoration of the immune landscape in Chromophobic RCC using potentially targeted cancer vaccines to elicit a better response to immune checkpoint inhibitors. I would like to thank all of our collaborators, Dr. Lisa Henske, my co-mentors, Dr. Dave Brown, Ali Van Allen, Tony Schwery, Dr. Sasha Chukla, and most importantly, the patients and their families, which are at the cornerstone of our work. Thank you very much.
Great. So maybe time for questions. We have one at the back, Dr. Burgos.
Hi. So I enjoy both talks. So I wonder whether one reason why the Emotion 151 trial may have not validated in Javelin, at least with respect to the angiogenesis component, is because in Emotion 151, arguably one was using a weaker angiogenesis inhibitor on one arm, the bevacizumab, compared to sunitinib on the other arm. Whereas in Javelin, you're having axitinib on both arms. So could you comment on that?
So actually we have sunitinib in both trials, but yes, maybe the fact that it is an FDA-approved regimen means that it is more potent and it has better results regardless of what group we're going to give this treatment to. And like it might be related to the biology of it being a VEGF and a TKI. Thank you for the question.
I'll ask a quick question. We're now doing prospective studies based off these RNA signatures. Do you think that's the right thing to do?
You mean right now adopt these signatures until proof of the contrary? Thank you for your question. I think that right now it's the best we have, but maybe before starting and expanding projects based on these signatures, we should indeed validate them in prospective trials.
One additional question I made: how easy is it to put, because with these RNA analyses, sometimes patients bizarrely can fall into two groups, into a virtual universe of two groups, and patients can be on the borderline of one group or another. How confident are you that you've got the patients into the correct category?
Okay, so actually we trained our model in the Emotion 151 dataset, and we got 100% of accuracy. However, yes, but then we used the Javelin dataset, and here we didn't have the same set of genes. So that's why we couldn't get 100% accuracy between the two groups. And it's mainly due, like we saw yesterday, to group number 7, because lots of artifacts affect small RNA, and also some assays don't really predict and detect.
I think, Tom, your point is well taken in that the methodologies for doing a cluster analysis is, by definition, every patient has to fall into a cluster. Whether they belong in that cluster or not, they are most like this cluster, but they're really not. So there's some inherent flaw in that. It's not like we're defining the clusters and saying, this is our group of patients. Like, some people may not necessarily fall into these 7. We're forcing everybody to fall into the 7. So there's an inherent bias, and I don't know from a bioinformatics standpoint how we overcome that, but I think there is that inherent bias.
I think we shouldn't be very like the study is the best that we have, the optics study. Don't be surprised if it's negative, but at the end of the day, are the patients losing? I think you have two combinations, equality and both first-line standards. So at the end of the day, folks are being treated. But this illustrates how hard, RNA-seq interpretation is, and second, why we may not be speaking IO, and IO VEGF. I mean, at the end of the day, if someone asks you what you want to treat, you say equality, Pembrolizumab, and Tulane. But when it's biomarker, we start saying IO, VEGF. I think, these TKIs, these VEGF TKIs, are not similar. Probably PD-L1 and PD-1 inhibitor are very different, or inside the PD-L1 inhibitor.
Europe, France did the bionic study. The bionic study also looked at signature. I'm not sure that was the right signature, in my opinion. I don't think that was a particularly robust signature. I think there may be shortcomings with this signature as well. But the fact that we're doing these trials in kidney cancer now is so important. And I think we should, and definitely want to try and make these trials successful, because if we don't pursue this approach, we don't have that many untracked alternatives, and it's going to start randomizing the PD-L1 expression or something along those lines.
The issue is the bionic studies. There are arms that have single agent TKI, and that may not be appropriate for a situation where I only treatment. Here, the optic study for studies two arms of therapies that are, applicable for patients, irrespective of the signature.
Then we have a question.
Yeah, then we have a question.
Another problem with the optic study is also that we don't get the data, we don't match the signatures, right? So sometimes we take like a large number of individual patients and then dissect it across the signatures, and the other one, you want to use a lot of information. I think it's too early to call it biomarker. I think it's a hypothesis generating signature. I think the element during this movement, which was I think you should be more careful before running something we all desire to have. I think it's too early to call it biomarker.
Thank you. There's a question right there.
Really nice job. Thank you. We obviously have, worked on the same data, so we can share notes and so on. So, I had some basic questions, right? So, what was the sample size for the javelin on the study?
Okay, so it was approximately,
No, just roughly.
yeah, so it was a big sample, approximately
600
yeah,
times.
800.
Yeah, 800.
Yeah.
Oh, so bigger than the emotion.
Yes, slightly bigger, like.
Okay, that's awesome. And so you said 100% accuracy. That's really impressive. Was that cross-validation?
Okay, no, so that was when we trained the model in the emotion data, but then we got approximately the same results as yours, so a bit more than 80%, like you said yesterday. Yeah, exactly, the cross-validation.
Thank you, Dr. Atkins.
Just a quick question about the same presentation. So do we know from the Javelin trial whether those tissues were from the primary or from metastatic lesions?
We had both, primary and metastatic.
Mostly primary. Right, and I don't think that the primary RNA-seq actually matches what is in the metastases. And so if we're doing trials for biomarkers, we should be looking at metastatic lesions, preferably within a year or so of the time of the treatment initiation.
Yes, you're totally
And we
right.
may find different answers.
Exactly, like the heterogeneity between the primary and the metastasis could be validated by liquid biopsies one day.
But you're spot on, Mike. When we did that work with the KCRS database, there's very different patterns of the clustering based off of site of metastasis between liver, lung, bone, compared to primary.
But when we look at TCGA and David Long paper, it was 95% similar. When we looked at our data and the TCGA and RCC. I mean, the goal is to find the signature. I asked Ari and Hakimi earlier, where it really predicts, at early stage, late stage, something strong that predicts all the time. And why not?
Right.
You're skeptical.
We have a question right there, Dr. Turin.
That's great talk, Doctor. Fantastic young investigators. Really applaud, a nice applause for Chris and Renee, really.
Yes.
So, Chris, about the chromophobe, one of the most challenging chromophobe to treat that has poor prognosis are patients with chromophobe who have sarcomatoid differentiation. Did you include in your, you did not, but maybe it would be a good idea to look at those cases and dissect and see what the sarcomatoid component in that chromophobe tumor that has sarcomatoid. Because obviously, I think you showed that chromophobe are cold tumors, very low T cell infiltration. You talked about exhausted T cells, but when you have very, very few T cells anyway, I don't know if we can really talk about exhausted T cells when there aren't too many of those. And I'm not sure the biomarker you used is the most robust marker to define T cell exhaustion. So maybe in the next subsequent project, you could look at some of these sarcomatoid with chromophobe where there is more immune cells and then really define what happens to these patients.
So I fully agree with you, Dr. Tanir, and that we should evaluate patients for RC with sarcomatoid differentiation. For the CD8 positive T cells, we're actually able to get a decent amount of T cells from these tumors. Even though they present with a low infiltration of immune cells, when we did the single-cell RNA-seq sequencing and the single-cell CRC sequencing, we were able to get around 6,000 T cells, which is a decent amount for the current analysis. I believe also that the evaluation of patients with localized versus metastatic disease is important. Now, related to the evaluation of immune exhaustion markers, I do agree that this is not an exhaustive list of immune exhaustion markers. However, we're trying to look here specifically at immune checkpoints. So PD-1, CTLA-4, LAG-3, TIM3, TIGIT, the most important immune checkpoints. This is not an exhaustive list of all immune exhaustion markers, and this remains to be evaluated, yes.
We need Andy Sewell to create a vaccine for chromophobe.
Well,
Next year.
well, great discussion. Thank you, guys.
Thank you.
Awesome. Thank you.
Thank you so
Congrats again.
much.
Okay, great. So if you want to bring up our, thank you.
Thank you.
You want to bring up our next two speakers?
Thank you so much.
Thank you.
Good luck. You got this.
My first.
Yeah, I'll introduce you. Take a seat. And then we've also got Cassim.
No, this is the next one. We'll start here, too, right?
So our next speaker is Regina Carrillo, who's going to be speaking on the impact of race and payer status on utilization patterns of partial and radical nephrectomy.
Thank you. Hi, good afternoon, everybody. I want to thank the KCRS Scientific Committee for considering our work for an oral presentation. My name is Regina Barragan. I am currently a third-year oncology fellow at the National Institute of Medical Sciences and Nutrition in Mexico City. And today I'll be presenting the work titled Impact of Race and Payer Patterns on the Patterns of Utilization of Partial and Radical Nephrectomy in Patients with Localized RCC. It's been described in the last decade or so that the incidence of early-stage RCC, mainly in high-income countries, has been steadily increasing. This is a reflection from both timely diagnosis and care and also better imaging tools. Ethnic minorities such as African Americans, Hispanic Americans, and Native Americans have overall a higher RCC burden, considering both a higher incidence and a higher mortality due to this disease when comparing, for example, with European Americans of non-Hispanic origin. The seminal work by Dr. Van Poppel has shown that the use of partial nephrectomies, also known as nephron-sparing nephrectomies, yield very similar oncologic outcomes when comparing with radical nephrectomies in the treatment of early-stage renal cell carcinoma. And it's been described an increase in the uptake of this type of technique as patients with partial or nephron-sparing nephrectomies, their likelihood to develop a chronic kidney disease or cardiovascular disease is lower than those patients that had a radical resection. It is important to note that as partial nephrectomies are a very specialized and minimally invasive procedure, some ethnic minorities, as I have mentioned, may not have the same access as European Americans, also known as non-Hispanic white, to these type of procedures, or even considering that they might be avoided by or may not be considered like adequate candidates for them due to the time of convalescence, also a higher rate of some postoperative complications, and finally, well, cost also. So taking all this into account, we hypothesize that patients that stem from minority groups, as well as patients that do not have access to a private insurance, have lower access to partial nephrectomies and therefore higher rate to radical nephrectomies in their treatment of localized RCC. So what we did, we interrogated the California Office of Statewide Health Planning and Development database, or also OSHPA. So this database, what it does, it accounts for all inpatient admissions, all inpatient and outpatient procedures, and finally all emergency room visits in the state of California. So we looked at this database in the time frame for from January 2012 to December 2018, and to analyze this, we use specific coding for renal cell carcinoma as well as the partial and radical nephrectomy using the CPT and ICD 9 and 10. We collected variables. I was making important put important attention to demographic characteristics such as race and payer status, and univariate and multivariate analyses were conducted to determine the association between demographic data and the procedural type. Overall, we collected data for 31,093 patients, and as we can see in these tables, the mean age at data collection for our patient was 57 years. Most patients were male, overall 57%, and as for the type of nephrectomy used, it's very equal both population, kind of 50-50 distributions. Most were white, followed by Hispanic, Black, and Asian, and most had either a private insurance or Medicare. So medical is a type of insurance we have in the state of California that are for those patients that do not qualify for Medicare but cannot afford private practice, they're eligible to have medical. As for the type of comorbidities, 1/3 had hypertension, followed by diabetes, chronic kidney disease, and frailty. And finally, most were treated in non-academic centers. So I'll use the line here at the bottom as the comparison from the overall population to other populations. And it is very astonishing for us when we saw this database that, for example, most white patients do have a partial nephrectomy when treating their RCC, but this phenomenon doesn't repeat itself in other minority groups such as Hispanic, Asian, and Black. When we look at the specific difference between groups, we can see that, for example, white have overall like a 6% higher rate of partial nephrectomies when comparing, for example, with Hispanics. And this is even more notable when we compare it with the other populations. So this was furthermore accounted when we made the union multivariate analysis, taking into account age, gender, and other comorbidities. So these findings were consistent when we tried all those specific dataset analysis. Furthermore, when we're looking at payer studies, something that was very surprising to us, first of all, is that when we talk about other populations, talking about the type of insurance, we're talking mainly about those who have, for example, veterans affairs type of insurance. So those were the patients that had the highest rate of partial nephrectomy. But when we compare, for example, patients with private insurance and patients with either medical or Medicare, we can see a difference of almost 50% with the use of partial nephrectomies versus radical nephrectomy. So it's very clear that some patients aren't getting probably the standard of care when we're looking only at payer status. So these findings were only positive by univariate analysis, but not by multivariate analysis. With all this taken into account, we conclude that race and payer status may have an influence on the utilization of radical nephrectomy versus partial nephrectomy. And the highest rates of partial nephrectomy were seen among white patients and also patients with a private insurance. We must take into account that these findings do have multiple potential confounders. So this database has an important limitation that does not allow us to have the granular data on specific staging. Nonetheless, we can see overall different types of procedure when we look at the global population. For example, other confounders we cannot take into account for this database are the latency of diagnosis as well as the complexity of the tumors. Nonetheless, we do believe that the access to care could be a driver of this type of phenomenon. So we must take into account that probably the first step to address this very complex type of disparities is to describe them, which is what we're trying right now. So I want to thank everybody for your attention. First and foremost, I want to thank my mentor, Dr. Sumanta Pal, and his team for allowing me to present our work, as well as Dr. Kai Dallas. And I want to thank two of my mentors from my home institution, Dr. Enrique Soto and Dr. Plon, who are two very important oncologists and great mentors. And finally, I want to thank the team, the fellows team from back home, as they're the ones actually taking care of the clinic and allowing me to be here with you. So thank you.
That was fabulous, great presentation. So we'll open it up for questions. Yes.
That was really nice.
Thank you.
I don't know anything about kidney cancer and surgical management, so I don't know resources, technical expertise that would be required to that. I wonder if you could cross-reference hospitals with direct expertise in your partial and the zip codes of individuals that are involved with procedures, whether that cross-correlation is a geographic dimension to the availability of a hospital, or the proximity of a hospital in which a patient will, as I said, my ignorance of the tertiary management KidneyCAN service, the training we have. So.
No, it's a great question. Thank you for that, actually. So the answer right now is no, we haven't done that. What we have done is also take into account for the multivariate analysis type of center that I actually forgot to mention that. So even though patients are treated either at academic or non-academic centers, this type of phenomena, especially the race difference, are always present. So we haven't done to that granular level, and we're not sure even if the database is going to allow us to do that. But at least in the type of center, we have seen this phenomenon once again.
That's excellent. Yes, go ahead.
A question for the location RCC. Given the roles of 5q amplification and P52 sitting in the region of 5q that's amplified, it was a little bit surprising for me that there's no subset of KCRS22 clustering with the DRCC, expecting some small portion of that. I think for the cell line, probably we can explain that because I think 76 when you both are the low P52 expressing cell, maybe link at each other once also the cell line actually way to address that. But what are your thoughts on why clinical samples could do that and now amplifying over that?
Yes, that's a good question. I think two things to clarify with that. First, I think the NRF2-driven signature is only a subset of the fusion-driven signature. And so when you do cluster them, there are all these other downstream pathways that are also going to make it distinct from the other subsets of RCC. And so the 5q dependent signature may get washed out there. And then the specific heat map that I showed is not actually clustered. It's ordered by subtype. So in that specific one, so there may be some aspect of the clear cell signature that they do share from the 5q gain, but that wouldn't have been in that particular slide.
Great. Go ahead, Nizar.
Should that show which fusion pairs?
Do you want to use your mic?
Which fusion partners pairs have that NRF2 signature? You know, the PRCC, the SAPSC, I mean, there are so many pairs. The other question, you mentioned at the outset of your presentation about the unmet need therapeutically. How does knowing this NRF2 pathway is, obviously, driving the disease in most of these tumors, what is the therapeutic, what therapies do you see we can apply this insight?
Great question. So I think for the first one, that's something that we have looked at a little bit. There are about 15 different fusion partners of TFE3 that have been reported. Unfortunately, because the numbers are so small, it's hard to see a signal whether the NRF2-driven signature is more common or less common with one specific fusion partner versus another. It does seem to be very strong if the fusion partner is ASPSCR1, which is one of the most common ones. For some of the other fusion partners, they are making up only a small subset of the aggregate cohort, so it's tough to say. And then for the second question, what the therapeutic implications are, I think unfortunately, the NRF2-driven signature in other tumor types is associated with kind of pan-drug resistance. And so it may explain a little bit about why this tumor type may be recalcitrant to many therapies. There, I think, are tool compounds and other compounds in development that will directly target NRF2, probably not quite ready for clinical translation yet, but I think the implication could be if this is really very defining molecular feature of the disease, we know it's directly downstream of the fusion, and there is a way to target that directly, that would be maybe the actionable aspect.
Do you see it in TFEB also, the NRF2?
Yeah, so we haven't looked functionally at TFEB that much, and there's very few TFEBs in the sequencing data, so we weren't able to see a very clear signal with TFEB.
Yeah, just to keep our virtual audience engaged, thank you all for watching at home, we've got a question from Ed Remzik. So first he says, wonderful discovery, Srini. He said, can you speculate why the TF3 mode of NERV2 activation is so specific to RCC?
Yeah, that's a very interesting question. I'm not entirely sure. I can only speculate. Two potential speculations could be one, fusions are a particular subclass of oncogene that are very strong, but also very dosage dependent, and you could envision that when you generate that gene fusion, it induces a lot of cellular stress, and there's this necessity to activate NRF2 coordinately to kind of, from the standpoint of the cancer, promote oncogenesis, but also tolerate the sort of anti-oncogenic aspects of the stress of generating that fusion. And that's been described for some other very strong oncogenes like mutated KRAS, et cetera, and NRF2. So that could be one reason. And then in terms of it being RCC specific, I think it's possible we may find that nuclear TFE3 in the absence of a translocation actually is found in a subset of other cancers across lineages, and maybe this mechanism would hold there too. And I think that would be something interesting to look into.
Okay, one more question, Tim.
So great talks. So I guess a question, a comment, the comment for Nisar. So this KEAP1 pathway, obviously, it's also activated in the FH deficient tumors because KEAP1 gets vaccinated. Obviously, there is a subset of papillary tumors that have the KEAP1 mutation, so it appears to converge with the translocation. So Srinivas, this NRF2 program, I mean, obviously you mentioned that this is one of the programs, and we have the lysosome and mTOR signaling. How prominently does it feature? Is something that you picked up in unsupervised analysis? How robust is this signature?
Yeah,
And then second question, the experiments that you did where you were knocking down TFE3, was that in translocation cell lines, or was it just endogenous? The non-translocated?
So the knockdown of TFE3 was in translocation cell lines. There's a very little phenotype when you knock down TFE3 in non-translocation cell lines, likely redundancy with the other MIT TFE family members. And the NRF2 signature shows up in various unbiased analyses as one of the top downstream when you compare it to the other subtypes of RCC.
Okay, I lied. I said there was going to be one more question. Sorry. Okay.
Thank you for the nephrectomy analysis. Have you seen any difference between 2015 and 2020 with time as people more know about the benefits of a partial nephrectomy? And are you planning to do this analysis for the rest of the US or Mexico or other databases globally?
The first question, we haven't done that analysis. So to be quite honest, I don't know about the current. One might believe that there's a higher uptake of partial nephrectomies as time goes by, as we have seen in other populations. This has been previously described, but in full honesty, in our database, we haven't done that. So thank you actually for that. We might take that into account for the future. And yes, actually, one of looking at the future, one of the goals we would like is to reproduce this type of analysis in other types, exactly as you mentioned, not only like limiting ourselves to the state of California or to the US, but also in other parts of the world. The main limitation to do this type of analysis in Mexico is the lack of very, actually a very detailed registries. So usually registries back in my home country are institutionalized in very selected centers. So this might be harder to do.
Thank you. Excellent. Great. Wonderful presentations.
Good job, guys. All right, and we move on to the final block, third and final block.
Thanks.
There you go. We'll start with Dr. Bilen, Mehman Bilen, from Emory University. He's going to present the data on the phase 2 results of the neoadjuvant cabo for locally advanced and metastatic RCC.
Yeah, thank you, organizing committee, for the kind invitation. Thank you, KCRS, for the great program. I know many people helped to organize. I didn't ask their permission, but I need to highlight two of them, like a Deb on the back and Meryl. I'm really honored to be their oncologist. each time I see them, I was amazed, because I know being on their feet is very difficult. They're on VEGF TKI, but they are on their feet, miking us, saying hi to us. You guys are amazing. And it's my honor, on behalf of my co-PI, Dr. Viraj Master, and all the co-authors, to present our data for phase 2 investigator-initiated clinical trial for neoadjuvant cabozantinib in localized non-metastatic clear cell RCC. And here's my disclosures. I think there is a couple possible role for pre-surgical therapy. For patients with localized disease, it may facilitate partial nephrectomy. For patients with locally advanced or unresectable, it makes the surgery easier or potentially help for organ sparing. And depends on therapy, it can give us some systemic effect and immune induction. And I think it will give us a lot of biological information in terms of responders and non-responder. Because of this reason, this is the space we are very much interested in. And the original idea for this clinical trial came from clinic. Back in 2018, we had this patient came to us. Dr. Master can remove anything and everything, but he felt this is unresectable, which I believe it's unresectable. And then we gave cabozantinib, and he had a fantastic response and become resectable, and he's still alive and disease-free. And then after then, we want to launch this clinical trial. And this group knows cabozantinib very well. This is multi-TKI. Is a standard of care for advanced metastatic RCC as a single agent or combination, and increased response rate with cabozantinib and other VEGF TKI neoadjuvant data. I think there is a role for further exploration. And today we're going to present our phase 2 data. And here's our trial design. Patients with biopsy-proven clear cell RCC, T3 or more, or any N, or deemed unresectable were eligible. They received 12 weeks of cabozantinib with a starting dose of 60 milligram Q daily. And after 4 weeks washout, they had nephrectomy and follow for long term. And our primary endpoint was objective response rate at 12 weeks. And we used Simon two-stage design. The first stage, 9 patients. If no response, we supposed to stop the trial. But if we see one response, we continue to enroll for additional 8 patients. And if we see more than 3 or equal responses, we reject the null hypothesis. And the secondary endpoints are safety, tolerability, clinical outcome, including DFS and OS, and surgical outcome and quality of life and others. And here is our baseline characteristics. Those fonts should be black. I don't know why it turned to white, but median age was 58, male dominant, which is 82.4%. We have 14 white Caucasian and 3 black Hispanic enrollment. It turned out mainly T3, and the median baseline tumor size was 90.2 millimeters. And here's our response data. All patients had tumor reduction, no disease progression. And particularly in this clinical trial, we also have a 6-week scan, and we didn't have any disease progression. 5 patients had a response, which is 29.4%, and 12 patients had stable disease. And the median reduction of primary renal tumor size was 23%, and this is 6 to 45% in range. And this is a couple images for patients who had a response. On the left, a baseline, on the right, follow-up. All patients completed 12 weeks of therapy, and 16 of them underwent surgery as planned without any significant delay. 1 patient refused to surgery for personal reason and want to get more systemic therapy. And 1 patient who was deemed to unresectable become resectable. That patient had a T4 disease. And 2 patients were converted from a radical nephrectomy to partial nephrectomy. And we see number of changes under the microscope. We had a fantastic pathologist helping us. All surgical margins were negative, and we see sarcomatoid differentiation in 3 patients. And there is number of changes, including necrosis and hemorrhage and inflammation, which we're gonna further investigate. In terms of surgical staging, 2 patients end up having YPT1, and the rest are T3, and 1 patient is still T4, on pathological staging. And in terms of ferment grade, is mainly grade 3 and 4, tumors. And here is our DFS and OS. We define DFS as a time to recurrence or death due to any causes. At the time of analysis, our median follow-up was 25 months. And we only have 1 patient had a recurrence, and subsequently died because of metastatic RCC. And this is the only recurrence so far. We have 2 patients die. One is due to COVID, and the other one is unknown, but those are not have any evidence of disease at the time of death. And again, this should be black, not sure why it's all the fonts are white, but adverse events are very similar, with other reported cabozantinib-based trial. We see diarrhea, hand-foot syndrome, nausea, ALT/AST elevation. We have 1 treatment-related SAE due to PE. And in terms of dose reduction, 5 patients end up needing dose reduction up to 40 milligram, and then 2 patients a needed dose reduction up to 20 milligram. We didn't see any grade 4 or 5 adverse event due to cabo or surgery, and we did not experience any immediate intraoperative or postoperative complications during this trial. And our conclusion is cabozantinib was clinically active and safe in the neoadjuvant setting in patients with locally advanced non-metastatic RCC. Additional data will be reported, including additional long-term follow-up. There is number of tissue or blood-based correlative studies, quality of life data, and frailty sarcopenia, and hopefully we're gonna report this in upcoming meeting. And we felt, after fantastic talk by Dr. Pauls and Dr. Powell earlier, I think this is the space we need to further explore. I think IO-TKI is a combination should explore, and there is number of clinical trial is up and running, and we have another IIT currently enrolling at Emory, which is Pemlan, 3 months surgery, and followed by 9 months of Pembro. And then hopefully this will give us another data to further explore. And I think non-clear cell is also another population we have to explore. We screened 22 patients for this trial, and 5 of them end up ineligible due to non-clear cell histology. And at that time, we didn't have any clinical trial. Because of this reason, we are working an IO-TKI concept in cooperative group, and hopefully we're gonna have a trial for non-clear cell down the road. And we thank to Exelixis for their funding and support. We thank all the patients for their participation, and also family member for their support. And I believe this space need a great collaboration between MedOnc and urology. We had a fantastic team at Emory. We opened this trial during COVID and enrolled during COVID, and this wasn't possible without great collaboration. And I'm very happy to have a great team over there. Thank you.
Awesome work. And next, we have Dr. Justine Penin from UC San Diego. She's going to talk to us about pathologic outcomes at cytoreductive nephrectomy following immunotherapy for patients with advanced RCC.
Thank you. So I'm so excited to introduce this wonderful collaboration. It was truly a grassroots effort between all of these institutions that are pictured on the slide. So before we get started, I just wanted to, a lot of you are here right now, so thank you so much. I have no disclosures. So just to go into the background of our study, so immunotherapy is one of the backbones of treatment in patients with advanced renal cell carcinoma. It can be administered in combination in the first-line setting or in the second-line setting where it is most commonly used. So the role of cytoreductive nephrectomy has been evolving over the past 10 years, and a huge landmark trial that really influenced this was the Carmina trial. And since it was published in 2018, more commonly, nephrectomy has been deferred. So as a result of this, there are limited data surrounding patients with advanced RCC that receive immunotherapy prior to nephrectomy. So in this study, we aim to characterize the pathologic and the survival outcomes of these patients that receive immunotherapy before their nephrectomy. Just to go over study design, so for our eligibility criteria, we required all patients to be locally advanced or metastatic disease that were not suited for upfront nephrectomy, and that was per urology assessment. All patients had to have received at least one dose of an immune checkpoint inhibitor prior to partial or radical nephrectomy. For primary endpoints, ours was pathologic outcomes at the time of nephrectomy following IO. And this was characterized by the degree of pathologic downstaging comparing baseline clinical T-stage and pathologic T-stage at the time of nephrectomy. Our secondary endpoints included progression-free survival and overall response rate. Just to review baseline characteristics, in total, we had 52 patients included in the cohort. The median age was 63 years. The majority of patients were male. Around 1/3 of patients were non-white, and the majority of patients had clear cell RCC. Around 85% of patients presented with de novo metastatic disease. 5 patients had sarcomatoid differentiation, and 5 had rhabdoid differentiation. In terms of IMDC risk, the majority of patients were at intermediate risk at 60%. So for treatment exposure, all patients had to receive at least one line of an immune checkpoint inhibitor prior to surgery. So the way that we categorize the different lines of therapy is illustrated in the figure. The median duration of systemic therapy prior to surgery was 8.1 months. And after surgery, patients either continued the same systemic therapy, switched therapies, or discontinued all systemic therapy. Out of the patients that continued the same systemic therapy, the median duration of systemic therapy continuation was 7.4 months. So for our pathologic outcomes, overall, we observed a pathologic downstaging in 44% of patients. And we also observed a pathologic complete response in 7 of our patients. 8 patients had pathologic stage T1 at the time of surgery. 4 of these patients had downstaging from baseline. None of the patients that experienced downstaging had rhabdoid or sarcomatoid differentiation. At the time of nephrectomy, the median tumor size was 6.5 centimeters. 85% of patients had negative margins, and 75% of patients had necrosis. So we wanted to highlight the heterogeneity of these patients that experienced a complete pathologic response in their primary tumor. So we included this table just to highlight their unique characteristics. So for treatment response and survival, we included a waterfall plot that highlights the imaging responses in the primary tumor for our cohort. And we wanted to highlight that the overall response rate for our cohort was 52.8%. And this included both renal and extrarenal metastatic lesions. The median duration of follow-up was 25 months, and the median progression-free survival was 3.5 years. We also wanted to highlight that we only observed 3 deaths in our cohort. All of those patients had pathologic stage T3A. 2 of those patients experienced downstaging, and 1 patient did not experience downstaging. So we concluded that cytoreductive nephrectomy is feasible post-immunotherapy in well-selected patients. We also concluded that IO is associated with response, and in some patients, an extreme response. Just to review some of the limitations of our study, we wanted to acknowledge the retrospective nature of our study and the fact that the majority of our patients that were enrolled were deemed eligible for delayed nephrectomy, and they all occurred at large academic institutions. No central review was performed, but we also wanted to note that all of our patients that experienced a complete pathologic response were reviewed by a site-specific GU pathologist. We were unable to report overall survival due to short follow-up and also the limited number of deaths that occurred. So for next steps, we hope to perform genomic profiling on biopsy and nephrectomy specimens in order to hopefully investigate markers of extreme response. And despite the limitations in our study, we do believe that this data provides a good framework and preliminary data for larger prospective trials that are investigating the impact of immunotherapy on prior to cytoreductive nephrectomy. And we would like to highlight some of these trials are SWOG 1931 or PROBE, CytoShrink, and Samurai. So just for our acknowledgments, we would like to thank all the patients and their families for helping us with this study. We also wanted to thank all of the investigators. It was such a pleasure working with all of you, and it's not just the people pictured on this slide, it's all of the medical students, trainees, staff, everyone that contributed data. I know that it was really a team effort, so I would like to thank you all. And thank you to my mentor, Dr. McKay. I've been working with her for 5 years. So, and she's truly the best mentor, so this is a pleasure. Thank you.
Sharing the stage.
Great job. All right, great. Congrats. Let's open up for discussion. Do you have a question?
So one thing that I saw with both of them is that your sarcomatoid tumors for both of these studies were the ones that didn't respond. So why do you think that is?
Yeah, in our study, those 3 patients who had sarcomatoid, didn't have PRs, they still have a tumor reduction, but end up having stable disease. And one of the patients who have recurrence and then die, he also have sarcomatoid histology. I think one way to overcome this, hopefully the IO-TKI-based approach with the utility of immunotherapy, I think makes sense. And hopefully this will deepening the response, for future trials.
Yeah, for our study, it was interesting because if you look at the pathologic downstaging and also the patients that experienced a complete response, none of them had a sarcomatoid or rhabdoid differentiation. And it's not really clear as to why, but what we're hoping to do is to actually take some of these specimens and do further analysis to hopefully further characterize. They did not, or they did not have downstaging. Yeah.
There was only 5 of them. Yeah, 5 of the 52, so.
So maybe you said this, but how were patients selected for this late cytoreductive nephrectomy? Were all those patients experiencing a systemic response when they had their primary removed? And therefore, it's a comparison of what's happening in the distant Mets versus what's happening in the primary. And then, if so, can you comment on what happened to their systemic disease?
Yeah, so I think for this study, we were very meticulous about characterizing the response in the primary tumor. We used renal scoring and actually looked at the individual images. And then for the systemic disease, we looked at the RECIST response, but it wasn't as meticulous as it typically is with pharmaceutical trials where you have the infrastructure to be able to do that. So I would say that our characterization of the primary tumor response is pretty accurate and illustrated in our presentation.
Yes, but I wanted to know about the systemic response. Were these all systemic responders? Because I'm not sure you do a cytoreductive nephrectomy in someone who's having
There was
disease
5
progression.
people that had a little bit of growth of their tumor. So